the Houston Health Department in the TB Control Department for over 12 years as a case manager for LTBI and 3HP patients. Tanya is an alumnus of the Lee College Nursing Program in Baytown, Texas, with 17 years of experience as a nurse. Following Tanya, our next presenter will be Kara Green. She's a board-certified family nurse practitioner working with patients across their lifespans in primary and preventive care. And Kara has been working in nursing and the medical field for more than 15 years and also serves as the Continuous Quality Improvement Officer for Hope Clinic. She graduated from the University of Texas Health Science Center in Houston with a master's degree in nursing and lives in Sharpstown. And joining Kara during her presentation, we will also hear from Hana Nori and Nguyen Tran, who are both certified medical assistants with Hope Clinic. So thank you all so much again for joining. We look forward to hearing about your partnership. We will have time for Q&A with the audience at the end. So for all attendees, just a reminder that you can submit questions or comments throughout the session, and we'll share those with the panelists during the Q&A segment at the end. So I think I will go ahead and turn it over to Tanya now to start our presentation. Thank you.
Okay, I'm so sorry for all the issues that we have with audio. Good?
I think we're good now.
Okay, first of all, I'd like to thank Kara Green.
Tonya, do you mind muting your screen or your Zoom and then just having your phone? Can you try now? Hi, Tanya, can you hear me?
Okay, can you hear me now?
Yes.
Okay. Okay, first of all, I'd like to thank Joe Lee and Kara Green for giving the Houston Health Department the opportunity to co-present at this TV Summit. We are very happy about being able to be a part of this. I'm just going to talk a little bit about how the partnership came about. In 2017, the City of Houston TV program started to expand our LTBI activities to focus more on prevention of TB disease by providing 3HP on-site at designated homeless shelters and increased targeted testing, TB testing, and treatment of high-risk groups. Also collaborating with community clinics that serve patients with high risk in a high risk community. This next slide is talking about, and at that time we had started using a new treatment which is called 3HP, and 3HP stands for 3 is 3 months. And H stands for isoniazid, and P stands for ribapentine. That treatment is a short-term treatment for LTBI. It's 12 weeks for 3 months, and they have up to 16 weeks to complete treatment. Okay, next, this slide here, we'll be talking about the scope of services that would be the criteria for the type of patient that will be able to be placed on the 3HP treatment. and that would be foreign-born patients who arrived in the U.S. within the last 2 years, patients who reside within the city of Houston jurisdiction, patients not planning to relocate and can commit to stay within the city of Houston area during the 12-week treatment period. Patients who are willing and able to come to Hope Clinic once a week utilizing their own transportation, and patients with medical high risk factors that weaken the immune system, such as diabetes and HIV. And also patients who have been ruled out for TB disease and have documented positive skin tests on IGRA and a normal chest X-ray. Next slide, Kara, please. After we started partnership with Hope Clinic, their responsibilities were to screen LTBI patient candidates who meet the following criteria. And at that time, we had agreed to enroll 20 to 25 LTBI qualified patients every quarter, and they would provide some medical evaluation and case management. They would provide 3HP clinic-based directly observed therapy, DOT, and ensure patients enrolled in the 3HP project sign a consent form or authorization to release information with the City of Houston Health Department and Bureau of TB. They would report and communicate to the Houston Health Department and Bureau of TB whenever a patient misses their DOT appointment and unable to contact by phone and or have missed several doses of time treatment. They would also submit DOT logs to the Houston Health Department monthly and submit DOT order forms as well. And next slide. Here you see the Houston Health Department Bureau of Tuberculosis. These are for our responsibilities, and we have said that we could do partnership with Hope Clinic is to provide and deliver 3HP medication, which is the INH and rifampicin. We would provide training and education related to the implementation of 3HP in the clinic. We would locate patients that have missed their appointments and or non-compliant, and provide consultative and technical assistance as needed, and then provide patient educational materials and pick up the talk sheet monthly from Hope Clinic. And here's an example of the talk sheet that is used for every visit to speak with the patient and ask them of any signs and symptoms that they may be having. And there's a list of those there, and patient sign, and also the person watch to take the medication. We have had great work with Sarah Green at the Hope Clinic, with Hanan and Wynn Tran, who have really been very excellent in helping us to provide the DOT. They've been very well with documentation. They help to give the patients enablers, which are gift cards, to help them to encourage them to come back and take the treatment every week. Right now, I believe we have about three patients that are currently on treatment. One is with in clinic, and then we have the other two that are on video VDOT, and then we recently got a referral this week that we'll be working on. So it's been consistent. The type of referrals that we receive post clinic has been really great in the medical management, and this program itself has really done a great job in helping to eliminate TB in the Houston Health Department. So, health department out. So, I like to pass off to Kara and her group. And let's see, I don't know if I have another slide or that Q&A.
Great, and thank you so much, Tanya. I think we're going to take questions at the end. And I just can't say enough about the Houston Health Department and Tanya. We love seeing her here in the clinic, and for us, this partnership has been really an important transformation for us in family practice care. Just a little bit about the Asian American Health Coalition and Hope Clinic, so you sort of understand our size and our staffing, those kinds of things. So we've been a nonprofit since 2002. We obtained FQHC status in 2012. Our main clinic site is located in Asia Town here in Houston, but we have 3 other clinic sites around the greater Houston area. Our DOT program operates currently out of the main clinic location here where we work. And I'll talk a little bit about some of our goals to sort of share this program among our clinic sites in the future. We serve over 23,000 patients across all our clinics, and we have practice areas, as you can see, in family practice, OB-GYN, pediatrics, dental, optometry, across all of our sites. Before our partnership with the city, LTBI treatment primarily consisted of a long course of INH or rifampin. For the 4-month course of rifampin was our most often treatment plan. And we really didn't have a lot of resources for patients without insurance. Even though INH is less expensive, rifampin, the cost of rifampin was a big barrier for our patients in choosing treatment, even with our 340B drug discount program as an FQHC. We do have a large refugee and immigrant population, which is part of our heritage. And it's really important to us here at the clinic. Our staff and our patients speak 14 main language groups. And then we have over 30 languages served. I think the last number I heard was 40-some languages served among our patients. So we really enjoy the diversity that we get to experience here at the clinic. And with that, that brings a large at-risk population for LTBI within the clinic. So as Tanya mentioned, we were approached by the Houston Health Department in 2017. They had other similar projects. Tanya mentioned some outreach to homeless populations, but also there's a large pediatric clinic in town that's private practice that they also had been doing some partnership with. But I think to my knowledge, we're the first FQHC they had done a partnership with here in Houston. So we did some exploration around what would this look like for our clinic? What was our staffing? How could we financially sustain this kind of a program without any specific funding? Definitely the incentive part has been really important for the patients. The patients get a really nominal incentive for coming to those visits to help cover the cost of their transportation or gasoline and to encourage them to come. But also just the staffing in terms of a programmatic piece, we had to look at how would we, without any specific funding, how would we go about sustaining the project in the long term, which was our goal. Also, we took a look at our latent TB infection rates and how many patients we had, how many patients that had been treated, so that we could really go into this project with eyes wide open. In 2018, in May, we enrolled our first 3HP patient. And this year we started more heavily into the video DOT portion. More of our patients seem to be interested in picking up on that modality. I think especially with COVID, that's been a really important transition for us. And we have some long-term goals that we're exploring about having some of our other clinic sites that are still within the jurisdiction of the City of Houston partner and join on board so that we can offer the service across other clinics, as well as our partnership with APCHO. And we did receive a mini grant, so we'll be outreaching to private clinics to sort of share our materials and experiences as well, to really break down the barriers with some of the private practice folks locally that don't think LTBI need to be treated. So a few statistics. Sometimes when I look at the 41, I feel like it's small, but really this program has had a lot of intangible positives for us as a clinic, at least that I see and that our leadership and our CEO has seen. Our MAs have really stepped up and done an amazing job, and they'll share here in a little bit. We actually have a new patient this morning, so it's super applicable that we're having this talk today because we had a patient referred from our refugee intake program that has no insurance. And this is a really important component as I discussed with her the option, she's really interested in video DOT, but having that available for patients really makes the treatment much more agreeable, and patients are much more willing to participate when they know that we have this resource for them. Early on in the program, we had a few folks lost to follow up, even with our partnership with the city, and that's been an important key factor for us too, is that as an FQHC, we don't have home visiting in our scope of services. So for us to be able to actually track down some of the patients, the health department has been really super phenomenal about finding patients. We did have a patient that moved, and we were working to connect them with through the migrant clinician network of clinics so that we could try to reconnect that patient with treatment where they moved. We did have a couple patients one patient that changed their mind even after commitment. We'll soon have a fourth patient in progress as of today. And then we had a couple patients we needed to stop, about 3 patients where we had to transition them to a different treatment regimen. We had one patient with some leukopenia that was persistent, and we did some consult on that. And so it's been a really exciting journey for us within the program. In terms of operational considerations, I think for us, things that have really built towards success are some of the things like having available hard copy forms. I know in this world of the digital age and the EMR, eventually we'll hopefully get to that point, but sometimes just having that paper on in a file holder on the wall, having the MAs have the paperwork ready has been really critical. We also have we use a quick reference sheet in terms of the dosage for the providers, any questions they might have about, which patients are appropriate for this kind of treatment and any contraindications or medication interactions. We also have found that having staff just ready to answer questions right at the minute. If the provider has to wait a couple days to hear from someone about their question, whether this patient is appropriate, we may lose that patient or the provider's interest. It's just as easy for them to prescribe a rifampin and send the patient with that prescription. So really, being on time and being super available by cell phone or in the clinic has been really critical. Also, we really have found that utilizing all levels of staff has been really important. As I said, the MAs, oftentimes the medical assistants are the ones who are doing that initial conversation to prep the patient and get them ready, start the conversation so that when the provider goes in, the patient has someone comfortable within their own language group who's talking to them in their same language. Having these conversations has been really important. They've been big advocates for the program, and we've been really impressed with their work in that. Also, I would say, having a place, just the physical logistics around scheduling. So we keep what's called a nurse lab schedule, where our patients coming in for immunization only visits or other injections, other medication injections. Within our EMR, we keep a separate schedule for that. And that's where we put our DOT patients, so that we actually have a workflow that we've been able to, sort of fold this into our other workflow so it has a home in the long run. And as I mentioned, video DOT, our patients have really been a lot savvier than we thought they might be, and they use their smartphone and they're doing the video DOT really well. Part of what we wanted to highlight today is just that typically we start thinking about providers as the driving force for 3HP or LTBI programs, but really for us, that's not been the case. In addition to the nursing and medical assistant staff, I also would encourage everyone, and for us it's been really important to involve folks like our front desk, our call center, our clinic leadership, our CEO and COO, to get all of those folks on board as stakeholders. But even our medical records, they're the folks receiving some of the documents back from the health department. The providers do provide that, evaluative screening. They're ruling out tuberculosis disease, ordering and doing those visits on a monthly basis for the medical checkup, and also evaluating those labs for any kind of issues that might have come up. But really, I think we found the most successful approach is having everybody in the clinic aware of the program, so that whether somebody's calling the call center, they're calling the medical assistant, maybe they're late for their DOT appointment at the front desk, we need the front desk to know, just as important as the back office to know, we are going to see that patient. I don't know if they're 15 minutes late, 30 minutes late, whatever it is. So having everybody on board so that they're not missing their DOT appointment has been really important. So I wanted to turn it over to Wintran and Hanan. I'll have them unmute. I'm so thankful that they were willing to be here today. I was going to ask them a couple of questions just about their experience. I know we started late today and we want to be mindful of everyone's time, but just can't tell them enough of how impressed we are. Really, we started this program and they've been able to pick this up, track the patients. They keep a tracking spreadsheet for us, and really we've been able to hand over this project to them in a way that, to me, they've shown a lot of growth and capacity here. Wintran and Hanan, do you guys want to share a little bit about your experience and the kinds of things you do here in the clinic around 3HP?
Sure. Yeah, we in here working together as a team lead, and whenever I'm not here, Hanan will cover me all the time, or whenever I'm not here, she will cover me. I will cover her. And whenever the City of Houston lady, Tonya, come back here and look for us, we're gonna, give priority and go there to meet her first. About we also have to train the MA in the clinic, how to give the medication to the patient, how to document it, how to complete all of the question in the chart. According to the training from the City of Houston, we got training from them. Anything else?
Hi everyone, my name is Hanan, and actually I'm glad to be a part in this program. I learned a lot, and that I'm pretty sure still there is a lot things more to add to my experience. And basically our work, it's less harder than the provider, what the provider does, but we take a first steps usually. We start with the patient whenever we know that patient has a positive TB. I start just to put the basic patient information on the chart, on the order sheet, attached all the labs needed, the TB result, and the X-ray for real, if they need it. And I just give it to the provider, they sign it, and we fax it to City of Houston. we let the patient know how the process goes. The patient has to come every week. If any missed of any doses, we let the city of Houston know. And of course, we let the provider who ordered the medication know about that. And our patient, they doing pretty good. I'm pretty sure because we provide them the perfect service, like language, like they don't stay here for a long time, especially if they don't have to come see a doctor. They come in only in a nurse visit. So that's, of course, they most of our patients, as Ms. Clara mentioned, they refugees, so they just start their life here. So they have a lot of things to do. So they don't want to waste their time in the doctor office. So they appreciate that whenever they come and we let them in and out fast, that's helpful for them. And yeah, I think we're doing perfect at this. We good, like we don't have that much of patients like complain or don't like to come. I know we used to open on Saturday, but now just due to the pandemic, we're not able to open. But a lot of patients, they like
Yeah,
that as well.
Saturday,
Yeah, because they come on Saturday, most of them, they have time. It's a day off for them. There's the other, I can tell, like a positive things we can add to the patient. Yeah.
So I was just gonna, yeah, great
Yeah.
feedback. I was gonna say, how do you guys find that you've been able to balance this with your other job duties? You have all your other work. How do you feel like the flow? You feel like it's something that's been, I don't know, you feel like it's something that you've been able to incorporate in other work, or how do you feel like you've been able to balance?
We try our best, and then we always give priority for the patient in the nurse lab first, because when they come in just for the medicine, and then it's really quick visit. They can take the medicine and can go right away. So and then we provide the different languages to the patient too. Yeah, so I think we will be able to handle
All the
both.
MAs, they aware about the process, how it goes, and based on the language, like for example, if we have a Spanish patient, Spanish MA gonna go and help. If we have Vietnamese MA gonna go and help. So that's helpful for the patient.
Yeah, that's helpful.
I agree.
Yeah.
And I think too, part of that cultural, barrier around feeling comfortable with asking questions they might not feel comfortable asking the provider about the medication, about if it's safety, do they really need treatment, is it important? All these kinds of questions. You guys have done a really good job. Coming from the patient's own culture, I think has really bridged a big gap for us. So. Thank you so much for sharing, and thank you so much to Tanya and our city partners for this partnership. I think it's been a really amazing journey for us, and we're excited to see where we'll go next. I know our timing is a bit off today. I don't know if we have time for questions or.
Yes, we do. We still have time. I think Evelyn said we can go a little over our original timing. So. Yeah, we're filtering through some questions from the audience right now. And I just wanted to start though by, I don't think our panelists can see these comments, but we've got some great feedback and people cheering on Hanan and Lynn for their work. Ed also says he'd like to clone you guys and send some MAs to him in Pennsylvania. And yes, so we really appreciate hearing from your perspective on all that you're doing. And another comment on how wonderful this collaboration model sounds. And people were really impressed with the work you're doing.
Thank you.
Yeah. And one of the questions that came through was someone said they work with immigrant populations as well, and they tend not to accept LTBI treatment. So can you talk a little bit more if your clinic experienced any treatment refusal?
Yes, so I would say we also have experienced this. I think some of the cultural norms around the treatment in other countries and acceptance of it as more of an endemic issue is part of what we've faced as well. And so some of the messaging and conversations that I think that I have with my patients and that we've tried to be able to overcome is so we call it sleeping tuberculosis. So latent is a really complicated word. And we have sort of broken TB down into two kinds. TB when it makes you sick, even though it's not two, it's the same microorganism. But and then we explain to patients that this is sleeping tuberculosis, and that later on in life, if they were to become sick or have other immune problems, it's possible that tuberculosis could become active inside their body. And for us, I think, and especially for me and my patients, a more convincing argument has been made when we explain their potential to infect others if they were to become active tuberculosis disease. So sometimes patients that have been reluctant to pick up and undergo treatment, when we talk about the potential for not only for them to become sick, but if they become sick and passing it on to their family members and others, especially their children, we've actually seen some patients much more willing to take on treatment. I think also importantly, we talk about these medications, or I do, as antibiotics. So it's really complicated when we try to explain the 3 different kinds of medicines and how they need to work together, and there's resistance, and all these things for many of our patients are just overwhelming. And so I usually start the conversation like I did with my patient today by talking about how we have medicine to treat this, and it's an antibiotic, and it's once a week, and it is longer than what you take for many other, antibiotic type medicines. But that once you're done with that treatment, and we have really good information that shows it would be very unlikely for you to have TB disease later on in life. So we try to, talk about this in ways that, that is approachable from the patient's side of view. I would say, we're not always 100% successful. You'll see we didn't enroll as many patients as we originally had hoped. But I think some of that is due to our refugee, and I know refugee numbers across the US have drastically changed over the last few years. Unfortunately for us, our refugee numbers are down. And so I think that's been part of what we're facing. I also, we have found too that within some of our community groups here in Houston, it's not necessarily when a community leader decides to take 3-HP, but we have seen where some family members, once they decide to take 3-HP treatment, other family members that also need treatment are willing to do that. So we've had some brothers in some cases, or cousins, where one decides to do it and the other one was a little bit more reluctant. Also, I think that accessibility piece that we talked about, having the Saturday appointments, was really critical for us, making it super available for patients. Also, I mean, we have our patient that changed their mind and sort of decided to decline after going through orders, had heard from another physician here in town that everyone has tuberculosis and there's no reason to treat it, because if everyone has it, then there's no point. And so I think for us, it's a process of being patient. So originally, the patient says, oh, well, I heard from someone else, I don't need to take this medicine. And we are in a process, it's an ongoing conversation. So right now the patient's not deciding to take 3-HP treatment, but we set up a follow-up and we'll readdress the issues, see if he feels a little bit more comfortable at that time period. I think also respecting the patient's wishes and sort of saying, hey, I understand this is a big decision. And it's a lot of commitment. It's an important commitment to your health, but maybe you're not ready today. Maybe, we'll give you some more information to think about it, research the safety on your own. We provide a lot of handouts on LTBI when patients have questions. And so, I think having it as an ongoing conversation instead of, like you said, no once, and that's it, we're not going to offer it again. Taking that same approach that we take with vaccines sometimes, where we offer again in a really, patient-centered way, is what we've tried to have as an approach to maybe, he may change his mind in another 3 months, maybe something happens, or, he has some other contact that might change his mind. So hopefully that's helpful to answer the question.
Thank you. And sorry, you may have touched on this, but have you all been using self-administered therapy as well for this regimen?
Yeah, through the video DOT program. And actually, I think the details of that are really interesting. So Tanya's team the Houston Health Department is actually the group that provides the VDOT platform. I think that would have been a really hard accomplishment for us to do at this point. We don't have that kind of funding or technology in place right now. We talked about utilizing that to help with other medication compliance. But for the city to be able to provide the video DOT, they're the ones that actually check those, the videos or the photos coming in for the patients. And so the patient's self-administering at home, but we don't have anyone doing it without the video component at this time. But we also talked about televisits as a way. We do have televisit capability. So, something that we've talked about exploring is, outside of the video DOT, we could also use the televisit, capability to watch patients take medicines at home in a similar kind of way.
And another question was, do you only train a few MAs specifically for this role, or would they all get this training and an opportunity to help with the 3HP medication regimen?
We have to train all of the MAs because, well, everyone needs to know how to give medicine to the patient correctly. So,
plus the languages.
Yeah,
they different languages.
but
so
the language barrier, so we really need all of the MA know how to give the medicine.
Also the shifts that they share. So we have an AM and a PM shift since we have after hours. So not every one MA is here at a certain time. We did focus, we trained a few, Tanya and the city did a really great job and and came during those first few, I don't know if they came during the first 2 or 3 patients to really be with us during those so that we're filling out the talk sheet appropriately and documenting any adverse, question mark symptoms, things where they weren't sure if it was, medication related. So the city was really great about holding our hand through that process at the beginning. And then from there, we trained, the other MAs. So we sort of used a train the trainer kind of approach. We did focus on our family. We currently have different teams of medical assistants. So right now our family practice MAs are the ones that administer the DOT. Pediatrics and OB-GYN MAs aren't involved at this time.
Related to the, I think it's great. It sounds like you have a lot of different languages, people who can interpret in different languages. But one person asked if when language assistance is not available, what has been your plan B?
We have a translation line. So we have we have a translation line. So we don't have every language. Obviously, we don't have Oromo speakers or we don't have a Kinyarwanda speaker, but there's as many FQHCs and other clinics experience in the world of TB, there's so many language options that we don't have. And so we use a language translation. We have a portable phone that we bring in the room and we put it on speaker, give the patient a handset, and we do that.
Okay, that's good. And okay, there's another question here about, I think, engaging the help of patients who have either completed their own treatment to help advocate for LTBI treatment to others in their community, or to provide encouragement and support to those who are currently in treatment, like offering peer-to-peer support. Do you have examples of that?
I don't know, Tonya, if you want to share. I know at the annual TB meeting, there's a really neat survivor story that has been shared within the Houston community. I love that idea, and I think we could really learn from that and really maximize it. Tonya, I don't know if you want to talk about how the city's done some work around that, maybe more on the TB disease side of things. We may have lost Tanya's audio again. I'm sorry, Tanya. If we hear you, I'll let you try to avoid talking quite so much. Oh,
I thought I heard.
Hello?
Oh, there we go. We can hear you. Hello?
Can you hear me?
Yeah, Tanya, we
Yes.
can.
Okay, I'm sorry about that. Yes, every year at annual TB Day, we do select several patients, and they tell their success stories. And it's really beneficial because we see them at their worst stage when they start TB treatment. And to see them, some of them who were treated for, say, spinal TB and couldn't walk, would walk through the doors that day. And it was just a complete transformation from the time that they started TB treatment. So we don't have like a peer group, or we don't have that type of setting because of HIPAA laws for it being able to talk amongst patients. But that forum has been beneficial for patients to come and share their story. So.
I would just add to that too. I was really impacted by the patient stories, and even though they're on the TB disease side of things, I think even as a provider, using those with providers that are on the fence about suggesting, we still have a few holdout providers that not here at our main clinic, but at other clinic sites that just based on their experience and situations aren't as likely to recommend treatment, and so I think those stories have been really impactful, even with providers, to suggest the importance of treatment so that patients don't progress into disease from LTBI. I love the idea of using, and I wrote that down, I think the survivor stories, even for, maybe it's not a survivor, but a patient medication story for a 3HP, we can get a photo and HIPAA release from a patient and do like a little short video. I think that would, especially in a couple different cultural groups for patients in their own language, I think that's a fantastic idea, and I think it would be a really worth our time. So thanks for sharing.
Yeah, I definitely agree. That was a great question from the audience, and I think patient stories, or people who are living with or at risk of a specific disease, we found even with the Hep B Foundation that patient stories and in language personal stories are definitely very helpful when encouraging people to be tested, to be treated, and to not stigmatize or spread misinformation about the disease. And also related to that, from Kate O'Brien in the audience, she mentioned the We Are TB campaign. So if people are unfamiliar with that, you can look up this network of stories and peer support from TB survivors and advocates, which is a great resource.
Yeah, we love that group. I think that's a great, thank you so much.
And hopefully I didn't miss any questions, but I don't see any more. Maybe we'll see if any more filter in if you guys have any last thoughts. Want to wrap things up. Sorry again to everyone for going a bit over time, but I think the poster presentations and networking is just starting in a few minutes. So, and this is all recorded. So if people are able to stay on a little longer, if they have questions, we can do that. And this will be shared as a recording as well, in case anyone needs to drop off at this time. But I will see if Kara and Tanya and Hanan and Wynn have anything else to say.
No, thank you so much. Again, really appreciate the attendees listening in and sharing their thoughts and questions. It's been a really great experience for us to learn from other programs, and we hope it was helpful for everyone. And we're happy to have, we'll be hanging out at the poster presentation, but any other questions, I'm sure our speaker information will be shared, and we're always happy to follow up with, afterwards, or even after the conference via email or phone, whatever would be helpful. To share and continue work around tuberculosis.
Perfect. Thank you so much. And I did notice there's in the chat, there is a link to the evaluation form. And if you complete the survey link, that's how you can also receive CME training for either attending this live session or the recorded viewing. And also wanted to highlight, because I noticed that the feature within the virtual platform that you can reach out to different attendees and speakers through the chat too if you have follow-up questions that didn't get answered during our session right now. So you can do that over the next couple of days during the summit. And yeah, I think that is it for this session. Thank you again to our speakers and to all of you for joining, and I hope you enjoy the rest of the summit.
Bye.
Thank you.
Thank you so much. Bye-bye.